Hey, good morning, and welcome to the UroPatient podcast. I'm your host, Vic Sinise. Welcome to the show. We meet here every Saturday at 10:30 a.m. And if you're watching us live on YouTube or Facebook, glad to have you on board. You can learn more about the show by visiting us at UroPatient.com, the best place to go to learn more about our show. Also, you can find all of our past episodes. Remember, this was created for you, the patient out there. I also created all these helpful handouts. Every time I have an episode, I've got a handout to go along with those episodes. You'll find them helpful. Check them out at any time. They're there for you guys. When we're thinking of pharmacological erections, it's the same chemical, two different ways to get this chemical in. One is injections, the other is urethral suppositories. So I'm going to start off with a talk just about the injectables. And I think that it's always nice to take that deep dive into the history of pharmacologic erections. So how did this whole thing get started? And it's kind of interesting guy. There's a doctor by the name of Giles Brindley. If you haven't heard of him, or maybe you did, he's kind of somewhat famous. He was he's not an MD, but he was I think a physiologist who was doing a lot of work in chemicals and mostly in things that had to do with the eye and color issues and stuff like that. But he got really involved in the problems with erections, so involved that he used himself as a patient and injected his penis with over 30 different drugs until he found just the right drug. That drug that he settled on was papaverine. Now, Dr. Brindley was pretty proud of his results. And actually in 1983, he presented at the AUA in Vegas. And what he did is he injected himself prior to coming on stage, gave his talk. At the end of this talk, he dropped his drawers to show off the results. Now, of course, it made quite a splash to the talk and made him well remembered. Although I think he took it a little too far, because he decided to give some of the audience the opportunity to confirm the degree of tumescence. With his pants at his knees, he waddled down the stairs, approaching the urologist and their partners in the front row. As he approached them, the erection waggling before him, 4 or 5 of the women didn't take it too well and threw their arms up in the air and screamed loudly. So I think you can make a little bit too much of a point. But anyway, that's what he's famous for. And that's kind of kicked off this whole erection by injection. A doctor who is a urologist, Adrian Zorgnati, began teaching patients, and he kind of perfected it a little bit with the papaverine, because you had to use a fairly high dose, and there's the higher doses, the higher the side effects. So he added phentolamine to the injections, to the papaverine, and began teaching patients about self-injection. And one of the urologists I worked with was really involved in sexual health, and he knew Zorgnati, and he also knew another guy by the name of Erwin Goldstein. And he actually told me, call this guy's PA. He's doing all the teaching. He says, I think you should get involved in this. So that's how I began teaching patients about self-injections. So pretty early on, all we had was phentolamine and papaverine to inject patients with. And the mixtures that I was using was 30 to 60 milligrams. And the phentolamine, which is Regentine by trade name, is 1 milligram. So that was always the same, and the 30 to 60 could be adjusted. And what you would mix is so that you would have a 1 cc would equal probably 30 milligrams with 1 milligram of phentolamine. And then patients could titrate that, or I could, figure out up or down if it worked too well or not well enough. So I began teaching patients about self-injection. Now, you might think that, when you got a needle and you're coming at a patient's penis, that you probably wouldn't have too many candidates for this treatment. Well, was I wrong? Because patients were coming in like crazy wanting to learn how to do self-injections. And the demand for me was getting nuts. So the docs started a clinic just for me on Fridays. I would do the erection clinic where I'd have patients come in, and I would be doing all this teaching. And back then I had to custom mix the medications. You couldn't get it from the pharmacy, but you could get the medications ourselves, and we'd make our own custom formulas for them. This was a little even before compounding pharmacies were around. So it was a pretty big demand. And I started wondering, where are all these patients coming from? Because patients were coming in and they were calling and trying to make an appointment with just me. They said, I don't want to see the doctor. I just need to see that nurse who's able to give me that shot. And of course, we never did that. The docs always saw the patients first and went through all the testing and requisites to make sure they were a good candidate. We worked as a team, but it was crazy. Then I found out how I was getting all these referrals. Well, I do have business cards, and patients were picking up those business cards, and they would take those business cards to their favorite bar and give them out to their friends. And our office happened to be right across the street from a bar called Petey's. And I found out the bartender had a whole stack of my cards that he was handing them out anytime one of his patrons would complain about, hey, things weren't working. I go, oh, go see this Vic guy. He'll fix you right up. So actually, I got quite a reputation in the erectile dysfunction arena for this. So papaverine and phentolamine were the two drugs that were mixed together, and this is what we were using. And they were great drugs. I mean, this really worked. It caused or help patients to deal with erection problems. And this was before any of these other drugs like orals were around. Only one small problem, well, maybe two small problems: pain and priapism. So this is one of the side effects of the shot, and probably the more serious one is priapism. But pain is reported in about 15 to 35% of patients. And it's typically, penile pain, although it can be groin pain, testicle pain. Most patients, it's not terrible pain, and they can deal with it. And sometimes it'll subside as they start using the medication. But there's a small subgroup, maybe 10% or less, that the pain is so terrible that they won't use the drug. I mean, it's just, they can't have sex. It hurts too much to like even touch their penis. It subsides after the medication wears off. So don't fear, but it is out there. I did a little research. Again, we're doing the deep dive for you folks. One of the ways that they talked about, there was a study that was done in 1996 and published in Urology, that you could slow inject the medication. And I think that's a real issue, because patients, when they're doing these self-injections, they usually want to just get it over with. So some of them will push the medications pretty fast. So if they're complaining of pain, one of the things that you can recommend is slow it down, take your time. Now, other things that can be done to help improve the discomfort or pain is changing what medications you use, what mixtures we use. We'll talk about some of the other options that are out there besides the papaverine, phentolamine, and prostaglandin E1, as we're talking about in this particular slide. But now, as far as priapism goes, prolonged erection can occur in about 18% of patients. This was tested with papaverine and phentolamine. However, I can tell you that prostaglandin E1 has similar results. There is a risk for patients that are going to, find out that they're going to get an erection that won't go away. So you do have to have some kind of plan in place. If you're going to do this type of work, make sure that your plan for what to do if somebody has a priapism is there. Now, one of the things that I found a lot of success with is Sudafed. And I always give the patients instructions that if their erection lasts over 4 hours, that they should have Sudafed on hand, a 60 milligram over-the-counter tablet. It's an antihistamine. Typically will get rid of the erection. It's worked most of the time, not all the time. There's been some talk in the literature about trying cold water and compressing the penis to try to help to get it to go away, but the Sudafed works the best. There's another drug called terbutaline that you can take. That's a prescription item. I never used it. Usually, like I said, most of the time the success with Sudafed was pretty good, but it's never 100%. So patients have to also be told what to do if it doesn't go away. Now, priapism is not something you can, just sit around and not worry about, because if the penis stays erect long enough, it can start to form some blood clots in there and can cause some ischemia, and could, permanently damage the penis, preventing erections in the future. So you have to have that plan in place, and patients have to be aware of it. I'll never forget a patient who called me, and he was one of my patients that was using the drug, and he was getting ready to get on a plane for a international flight, and he injected himself at like 2 a.m. in the morning. And now I just got to the office and it's like 6 o'clock. So he's had this erection now for 4 hours. It won't go away. And he's calling, and I get the call, and he goes, "Can I get on the plane?" I go, "Absolutely not." He says, "But it's an international flight." He says, "I can't, I'm going to lose my money on it." I says, "You may lose more than your money." I says, "It's bad planning." So, this guy obviously had to go in an emergency room and get treated. But that's just kind of, some of the things you need to make sure patients are aware of. Probably not a great idea to give yourself a shot right before you're going to get on an international flight. The other issue with injections is plaque formation. So you can form these plaques sort of like a Peyronie's from the injections. One of the things we always tell patients is you can't inject every day. We recommend no more than, like, I always say 12 times a month, but 2 to 3 injections per week. And they're not really sure what causes this. It could be just the physical, poking through the cavernosal body that could set up a scar. And it obviously doesn't happen to everyone, but it can happen. And severe, it'll cause curvature. I will tell you that in my career, I've only seen a few plaques form. I've never seen one cause curvature, but they can form these little plaques. We always recommend patients that are on injections, make sure that they have their urologist examine the penis yearly to make sure there's no plaques. If they're forming plaques, this is probably not a good treatment option, because then again, they could become severe enough that they may need to have intervention done to treat those. Now, fortunately, we have the same drugs that they use for treating the Peyronie's disease can be utilized for these plaques to help dissolve them. But some people just are going to form plaques for unknown reasons, and the injections can be one of those causes. Now, this is kind of a funny story. So back early on in my injection career, again, I was mixing patients, the papaverine, phentolamine mixture for patients, and a drug rep from Upjohn stops by the office and says, "Hey, I hear you're doing a lot of this erection treatment stuff." And I go, "Yeah." He says, "I got a drug I think you should be interested in." He says, "We use this drug called Alprostadil to treat patent ductus arteriosus in children." But he says, "I know a lot of doctors now that are treating erectile dysfunction with it." Now, Alprostadil is prostaglandin E1, and it's the backbone of erectile injections. The dose is very low, 10 to 20 micrograms to work. And so he said, "I'll get you samples," which was great. Anytime you can get free samples. So talked to our physicians that I worked with and said, "Hey, this new drug just came out. I think it sounds pretty promising. Little cleaner profile than papaverine. Papaverine can have some effect on liver enzymes. So if you're using papaverine, you should be running, normal patients should have a liver enzyme check just to make sure there's no changes. I can't tell you a patient I've seen that has had a change in their liver enzymes, but it's possible. But prostaglandin E1 doesn't have any effect on the liver, so a nice clean drug to use. So that's where I started switching over. So it was you dilute it down, and you want to get anywhere between 10 to 20 micrograms per cc, and then you could titrate, because I utilize those syringes where 1 cc is insulin syringe. So each unit at 10 units is 1/10 of a cc. So it can be a 1 cc insulin syringe that you use to inject, or you can use a 1 cc like tuberculin syringe, which is marked off in 1/10 of a milliliter, or units for the diabetic syringe. But those are the ones that I always utilize. So it's nice to titrate that way. But in July of 1995, Pfizer came out with the first FDA approved form of prostaglandin E1, and that was the Caverject Impulse. And the one drawback of prostaglandin is it's temperature sensitive. So if you left it sitting out on the counter, it's going to be garbage. It won't work. Won't hurt them, but it won't work. So you have to keep it refrigerated. So that was always an issue. And that was an issue with the FDA as far as approving it in its native form. So what Pfizer did is they powdered it so that it could be kept at room temperature for storage. And that's what the Caverject Impulse looks like. And it's kind of a neat little syringe system. So what you have is a mixing syringe. You put this little cap on at the time of you're getting ready to utilize it. So it punctures this little cap in here. So everything stays nice and sterile for you. And then you go to this plunger rod and you start twisting it. And as you twist it, it starts to push the water that's inside here into the powder. The powder will mix instantly as soon as it gets wet. And you've got your dose mixed. And then it has this dose window so you can actually twist it. So the 10 microgram will give you 4 different dosing options. So you get 2.5, 5, 7.5, and 10. And then the 20 will give you up to 20. Again, the same type of breakdown. I think I've got some figures on how you do this. So as you can see from the figures, is you wipe off the tip with some alcohol, take off this little protective covering, screw that on, then you twist that, and then this is what the dose looks like. So you can see the number in there. So you always want to find the lowest dose that works. I can tell you that every patient wants to try the highest dose there is because they think they're going to get a better erection. Doesn't work that way. More medicine does not cause a harder erection. Once you achieve an erection, that dose is going to give you as hard as erection as you'll get. More medicine will make a longer erection. It's the high enough dose, you're going to put your risk for priapism up. So always try to use the lowest dose and stress that to patients. But I can tell you, guys are funny. They give me the biggest, baddest dose you have. In 1997, a company by the name of Schwartz came along with a dose of Caverject with their own type of dispensing system called Edex. Edex was my favorite drug to use. And the reason I liked Edex the best was because it came in 10, 20, and 40 microgram. I can tell you that I've had patients fail at 20 and succeed at 40 micrograms. So having a little larger dose goes a long way. Very similar type of setup here, where you have this, this part here is reusable. You just open this up and then this little cartridge goes in, and this cartridge has a little bump in here. So it only goes one way, and you just slide that in as you see here. And then you screw that little plunger mechanism onto the back, and then you push it forward, and it does the same thing as you push the water up into the syringe here. You start to push this up, it has the water column between these two little stoppers, and it reaches a point where it goes up and over that, and then gets the powdered prostaglandin wet and causes it to reconstitute. I say prostaglandin E1 reminds you of powdered sugar. It reconstitutes that easily. And as you can see, then you can, again, as you see from this blow up here, you can control your dose by the amount of medication you give. Now, you're always wasting with all these drugs. If you're giving less than a 1 cc dose, you're going to just waste it. You can't save it for other uses. That was kind of the things patients liked about the ampule of medicine that they kept in their fridge. They could just draw out their dose. So if they're using 1/10 of a cc, 1 cc goes a long way. But again, this one, you don't have that option, but you control your dose. This one doesn't have numbers, but it's 1 cc, 0.75, 0.5, and 0.25. Now, I always teach patients to do self-injection the same way. I find the best system to do this is to have the patient grab hold of the head of their penis. If they've got a foreskin, pull the foreskin back so you're grabbing the head of the penis, because the corporal bodies are going to be attached to the head of the penis. So if you're pulling the skin, you may not really stretch out the corporal bodies. You want to stretch it, pull it across the skin, and then inject anywhere in this area. I find that closer to the base, the corporal bodies are bigger and they get narrower as they get towards the head, but as long as you hit them, it's going to be fine. That needle looks a lot longer than it is. A 27 gauge needle. I think it's a 0.5 cc in length that comes on the kit. And this is really another nice example of how this area that you want to be able to show patients to inject in. And that's kind of the technique going in. I always tell patients the easiest way to do this is bring the needle right up to your skin. Just kind of touch the skin and then give it a good hard push to bury it. The cavernosal bodies are pretty hard. They're pretty tough. And as you try to push through that, I've had patients inject under the skin, and all they do is get a nice little blurb bleb underneath the skin, but they don't get the reaction. It doesn't work. So I always tell patients, make sure that you bury it. And I find it's really helpful if you've got a model in your office or a diagram like this that you can show patients and show them what they're going through, that they're going through the skin, this tough buccal fascia, until you get into this corporal body. And you want to make sure that you bury the needle, because if you don't, you can inject in this space. I think if you make that clear to patients, they'll do a pretty good job. Now, the other thing I warn patients about all the time is to make sure that they're not injecting on the top, not injecting on the bottom. So the top is a nerve, and if patients inject the nerve, it'll hurt. So patients will complain of pain just from the injecting the nerve. I can tell you that for most patients, they're surprised when they go and inject the penis on the side like I'm showing. They don't feel the needle. The needle's so small that it's not really something that it can sense. So it's I always say that it's small enough to miss all the nerves. The way the penis is designed, all the nerves are towards the head. So the side of the penis doesn't have a lot of nerve supply. You don't want to be injecting on the lower down here, because that's the urethra. I've had patients do it. They inject in the urethra, common call. Hey, I gave myself a shot. It didn't work. And I saw blood come out the tip of my penis. I go, yeah, you injected too low. Now, is there any danger to that? No, it's just usually kind of, distressing to the patient to see blood come out. But I've never seen any, strictures or anything happen from that occurring. But again, definitely worth warning them about. This is a nice chart that was put out by Pfizer on their particular drug on how to titrate it for vasculogenic, psychogenic, and mixed etiology cases. I can tell you that one of the big problems one of the problems patients face with erection is something called performance anxiety. And we had a doctor in our building who was a psychologist that we would refer in the past to for patients that were having performance anxiety, and to do some psychological treatments for them. Well, that guy started sending patients to me. He said, because I had higher success rates with my injections than he ever got with his psychotherapy. He said, sometimes if a patient's got performance anxiety, long as they've got the shot and they get a few under their belt, all of a sudden they don't have to worry about, hey, if I can't get an erection, I can always go in the fridge, grab a syringe and give myself a shot. That takes that performance anxiety away. And most patients, and after about 6 months, they don't have to use the shot anymore. So it's really been a good treatment for psychogenic issues. But anyway, this is the titration they recommend. So they starting dose of very low at 2.5. If it works, great. There's the dose. If it doesn't, they get a partial erection. Then they go up to 5 micrograms. So another second injection. Now, this titration, I don't recommend anybody to send patients home and titrate at their house. This should be done in the office. So you should have a kit that you can give the medications and titrate. So you're looking to see if you get a full erection. Now, you don't have to have the world's, hardest erection. And you have to keep in mind that this may not be the best situation for getting an erection. I always say I'm a nice looking guy, but I'm not going to cause any great erections in the office. So you have to keep that in mind, but you want to push on the head of the penis. And if it doesn't buckle, that's what you're looking for. And all of this, patients should then titrate at home once you get a baseline of where you think you're going to need to be. But anyway, I don't know that I think that this is the best system for the titration. It's not the one I use. So I'm going to give you what I use. And this is experience. I started 10 micrograms. Almost all patients can tolerate 10 micrograms without ending up in the hospital with priapism. So it's a good starting dose. If the patient, again, has no reaction, I would then go ahead and inject them with another 10 micrograms to get it up to 20. So I'm trying to ballpark it. Now, if the guy gets a pretty good erection at 10, you don't go any higher. And depending on how hard it looks, if it's like a really good erection, younger guys, I might prescribe the 10 micrograms, but tell them to start at a lower dose, 5 micrograms, even the 2.5 micrograms. You're always looking for the lowest dose possible. But again, we're trying to see if we can cause an erection, and some patients need higher dosages. So we're up to 20 micrograms. This is all in the same setting. I come back and I give it a half hour in between each injection. If at 20 micrograms, there's still no erection, I'll go ahead and give them an additional 20 micrograms to bring them all the way up to 40. Remember, Edex goes up to 40 micrograms. So your goal is to try to test to see whether they're going to be a candidate for pharmacologic erections. In the old days, I would bring patients back and do these tests, try a 10, try a 20, try a 40. That's 3 trips to the office. Patients are busy. I'm busy. And if they keep giving away my cards at the bar, super busy. So I think the going and having a test method that works is good. Now, you might say, well, why is it not working in patients? Because this stuff is pretty successful. Well, there is some issues of something called venous leak syndrome, and I'll talk a little bit about that in a moment. But that's what I'm trying to prove here is whether they have venous leak syndrome or not. Because if they do, none of these injections are going to work. Now, I am going to put a warning here, and this I do like. So they have this pure neurogenic etiology, patients with spinal cord injury. If you're not prepared to deal with these patients, I would avoid teaching them or dealing with them, because they are the ones that are going to get in trouble with not only with the issues of priapism, but they get the wacky blood pressure changes and heart rate changes from the side effects too. You've got to start with a very low dose. My standard dose is 1 microgram to start. Now they show 1.25. But anyway, I start very low and see what happens. If they have no reaction, then I'll gradually work my way up. Most patients with spinal cord injury, doses of 1 microgram sometimes is all it takes to work. And you have to really be careful, because if you came after somebody with a spinal cord injury with a 10 microgram starting dose, you might find yourself in a lot of trouble. So I will warn you about those patients. It's a special case scenario. I've dealt with them in my career. Your physicians in our practice were quite comfortable with it. So was I. But again, that's the warning. You have to make sure that you keep that in mind. If somebody's got some kind of spinal cord injury, don't go hog wild with this. And they have to know the same thing. They've got to be very careful in their dosing. Success rates of it. One of the things with injections is they're a high rate of success. The issues that patients have are, needle phobias. Some patients don't want to stick themselves with a needle. Once you get them through the first testing injection, that tends to go away, but that's always one concern. But success rates are great. I'm going to tell you that I can get success rates probably even closer to 90 to 95% with the use of compounding pharmacies, because you can special mix this stuff and come up with something that'll work for most patients. So it's really a great thing to be able to offer patients as a treatment. So compounding pharmacies are available, and they've got all sorts of mixtures that you can come up with. And the big thing is right now, if you're going to go into a compounding pharmacy, most of them are using what's called trimix. So it's papaverine, phentolamine, and alprostadil, our prostaglandin E1, mixed together. The 3 drugs have a symbiotic relationship. They all boost each other, and you can use much lower dosages. So remember, I was saying, my concern was papaverine and liver, but we're down to 18 milligrams versus what normally would be 40 milligrams for most patients. So we're using very low dosages of these medications, and standard dose will work. And when you mix standard dose, the patient may not be injecting a whole cc either. Half cc, whatever works, the smallest amount, titrating it up. Now, this is what I like about compounding pharmacies. They're cheap. One of the big issues, and patients that started out with me before the approval of these drugs, the prostaglandin E1s, Edex and Caverject, they were getting their medications for, dollars a shot, compounded. But now all of a sudden you're paying for the cost of an injection, and those injections were not always covered by insurance, mostly weren't, and they're fairly expensive, especially early on. I'm not sure what the current cost is. I meant to look that up, but they are not inexpensive. So they hated it. So a lot of patients wanted to go to something else with compounding pharmacies, and trimix fit that bill perfectly. The other thing I like about compounding pharmacy are what's called the super mix. So that patient that just requires higher doses, what I would typically say maybe was a failure might be somebody I can rescue with these high dosages. And you can look it down here, they're mixing 80 milligrams of 80 micrograms of phentolamine with 25 milligrams of papaverine, 3 milligrams of regentine. So they're using these super high mixtures. And I have had some patients that are using the high mixtures and getting erections just fine with those. So if that's required, it does give us an option. I always say that you have to have options for patients. Now, if you're going to do this, I highly recommend that you've got handouts to give patients. This is a compounding pharmacy that we use called Anazao Health. They are out of Vegas. They're always look into the compounding pharmacies you're using, because you don't want to pick somebody who's not, properly following the regulations that you should have. Always have the patients waiting 3 days between injections, telling them not to inject more than 12 times a month, keep the mixture refrigerated. And then I think this is the important part here, is what dose of the medication I want them to use and the titration. And I tell patients wait 3 days before increasing your dose, and you're increasing it by 0.1 cc's or 10 units until satisfactory dose is reached, and a max of 100 units. That's 1 cc. Don't be discouraged by poor results, because sometimes the first result's not your best result. And then again, down here, this big warning: if you don't, if you have an erection over 4 hours, Sudafed, apply an ice pack, wait an hour, still erect, you're calling us, you're going to the emergency room. So let's talk about urethral suppositories. I'm going to kind of go through those quickly because not my favorite drug, but in 1996, an option to injecting it, you can give Alprostadil, prostaglandin E1, in the form of a urethral pellet. And it comes in 4 different doses, 125 up to 1,000. I can tell you that most patients require the 500 at minimum to work, and up to 1,000. Now, remember, 20 micrograms injection will work. We're giving 1,000 micrograms of this medication. What's that going to spell? Probably more side effects. Comes in a easy to use dispenser, this little button thing that has the pellet. The pellet's right up here in the tip, and you put that deep into the urethra. I've got a picture of how that looks. You just kind of slide this into the penis, a little lube on it to get it in there. And then you go ahead and you push this little button on the top, as you see that finger up here showing. You're pushing that button in, and that'll release the pellet. Once the pellet's released, you want to make sure it stays within the penis. They recommend massaging it to help it dissolve, because it does have to dissolve. And then the prostaglandin is absorbed through the urethral walls. Absolute contraindications are priapism, sickle cell, multiple myeloma, and leukemia, anything that can cause cells to stick, peyronie's, and a penile implant. Obviously, you stick a needle through a penile implant, it's going to leak. But even using the things like the pellets, although it wouldn't puncture it, it's not going to work. Once you have a penile implant, as we talked about in the second part, it's not going to work. So side effects with all these drugs to be careful of. Most of them can lower blood pressure, especially from going from sitting to standing, the orthostatic hypotension. Again, I talked about the pain issue that can occur. Also can be increase in heart rate and fainting, so that standing up too quickly after your blood pressure drops can cause patients to faint. Now, it didn't occur too often with the injections, but with those high doses that we use with the urethral pellets, the mousse, it does. Patients should be warned alcohol and cannabis products should not be used at the same time, because they can potentiate the effects. Be careful when operating a car or heavy machinery until you know how well it's going to work, as any effects that it might have, just like you'd warn any other patient. And the PI will tell you that you need to start at a low dose and work your way up. So really, the way you're going to do this is to titrate it. It should be done in the office. So you have a patient that'll probably come to the office 3 or 4 times to properly titrate this. And when you had samples, it was great because you could try it that way. But I don't recommend sending patients home to try this themselves, because I've done enough of it. And patients should be brought to the office and titrated in the office so that you can monitor their blood pressure and make sure that it's not going to bottom out on them and they'll pass out. Worse than that is I've seen this big distended veins in the legs from it, and it hurts. Patients are nervous because of the pain from it. It all goes away over time, but it's something I never saw with the injections. I kind of mentioned I'm not a big fan of the mousse pellets. There's why. Also, women have to be partners have to be aware that it can be when they ejaculate, the medicine can get into their vagina. It may cause some irritative effects. If it does, obviously a condom can prevent that. If you're pregnant, it's absolutely not recommended to utilize without a condom. So I hope you enjoyed this episode. We'll see everybody next week on UroPatient.com.